You know those ER doors? They fly open dozens, sometimes hundreds of times a day. And right there, in that moment, a doctor has to make these insane life or death decisions, all based on this vast library of knowledge they have stored in their head. So today, we're going to peek inside that library.
So what exactly does it take to think like an ER doc? I mean, what's the difference between a medical student and the person you're literally trusting with your life in a crisis? Well, we're about to find out.
So for this explainer, we're not just flipping through a textbook. Oh no, our source is way more intense. This right here is from a question bank for the final exam that every single aspiring emergency medicine specialist in the UK has to pass. It is the ultimate test. And we're going to use its questions to try and see the world, just for a little bit, through their eyes.
All right, so to really get what this test is all about, we're going to run our own little shift today. We'll start with the test itself, and then we'll dive into our cases: major trauma, decoding the body's hidden signals, treating a tiny patient, and playing medical detective. And finally, we'll see why this is so much more than just an exam. You ready? Let's clock in. Okay, first up, major trauma. This is where speed and structure are everything. I mean, the clock is literally ticking from the second that patient bursts through the door.
Imagine this. The paramedics rush in. You've got a patient from a car crash. They're unconscious. A dozen, maybe more things could be wrong. So where do you even start? What's the absolute first thing you do?
They don't guess. They start with what's called the ABCDE approach. Think of it like a mental checklist that's just drilled into them, and its whole purpose is to bring order to absolute chaos. So they systematically go down the list. A is for airway. Is it clear? B is for breathing. Is it effective? C is for circulation. Is there a pulse? It's like this universal script to save a life, and you better believe it shows up all over their exam.
Okay, so once the patient is stable, the real investigation kicks off, and they have to look at an image like this X-ray and know exactly what's wrong in seconds. To you and me, it might look a little weird, but to a trained eye, the injury is crystal clear. The head of that arm bone, the humerus, is totally out of its socket. Spotting this specific injury, an anterior shoulder dislocation, and dozens of others, well, that's a core skill they absolutely have to nail for the exam. All right, let's shift gears and move to our next case. We're going from the obvious physical trauma of a crash to something way more subtle, the body's hidden language. This is where the ER doc puts on their detective hat.
Okay, so a 61-year-old woman comes in. She says her heart is just racing, feels like it's fluttering in her chest. The doc hooks her up to an ECG machine, and boom, this is what they see. And the exam expects them to look at that and instantly recognize the chaotic, irregular rhythm of atrial fibrillation. And not just that, but to spot that super high heart rate, 144 beats per minute. That's way too fast.
And then, just a few minutes later, another patient comes in. This time, it's a 40-year-old guy, says he feels faint, and his blood pressure is dangerously low. His ECG looks like this, a completely different pattern. What they're seeing here is a total breakdown in the heart's wiring. It's called a complete heart block.
Okay, so let's put these two side by side for a second. Now, to most of us, this is just a mass of squiggly lines, right? But to an ER doctor, these are two totally different crystal clear signals. One heart is beating way too fast and all over the place. The other is beating way too slow and failing. The treatment for one could literally kill the other, and they have to know the difference in a heartbeat.
And look, the signals go way deeper than just the heart's rhythm. From just one tiny blood sample, they can see the body's entire chemical balance. It's amazing. This table here is basically their decoder ring. So, for example, just by looking at the pH and CO2, they can tell if a patient's breathing is failing, like in a bad asthma attack. Or they can see if their metabolism has gone haywire, like with diabetic ketoacidosis, which makes the blood dangerously acidic. Each of these patterns is like a chemical fingerprint pointing right to the emergency.
All right, time for our next case file. And this one, the patient is a child. When it comes to pediatric emergencies, everything changes. The drug doses, the anatomy, it's all different. And the stakes just feel impossibly high. Every single decision is magnified.
So a frantic parent rushes in with their toddler who's having trouble swallowing. They take an X-ray, and this is what they see. This perfect, circular, metallic-looking object just lodged right in the kid's throat. So the big question on the exam is, what is it, and what on earth do you do?
And the answer? It's one of the absolute most dangerous things a child can swallow, a button battery. See, once it gets stuck, the electrical current starts a chemical reaction.
And that reaction can literally burn a hole through the esophagus in as little as 2 hours. 2 hours! So this is why it's not enough to just know what it is. They have to know the extreme urgency. This is not a wait-and-see kind of thing. It is a flat-out race against time to prevent a catastrophic injury.
Okay, for our final case file, we're going to look at how ER doctors think ahead. They aren't just reacting to what's happening right now, they're always planning for the next 5 minutes, the next hour. They have to be like medical detectives, always thinking about what's coming next.
So take a situation like this from the exam about sedating a really agitated patient. The doctor can't just know what drug to give. They have to know the details. How do you give it? How fast does it work? How long will it last? I mean, is this drug going to kick in 1 minute, or is it going to take 30? Will it wear off in half an hour, or are we talking 3 hours? Picking the right drug from a table like this is the difference between controlling a situation safely or not.
And this kind of forward thinking is just perfectly captured when they're getting ready for a supercritical procedure, like intubation, that's putting in a breathing tube. They run through this mental checklist called the Lemon Assessment, and honestly, it's a lot like a pilot's pre-flight check. Every letter is a prompt to check something that could make the procedure really difficult or even dangerous.
So let's just zoom in on one tiny part of that check. The M stands for Mallampati score. Basically, by just having the patient open their mouth wide, the doctor gets a preview of how much room they'll have to work with. A Class 1 view, where you can see everything, that's the dream, easy. But a Class 4, where you can't see past the tongue, that is a potential nightmare. And that simple visual check, it's critical data that changes their entire plan.
So as we've walked through these cases, from trauma to toxicology, from adults all the way down to infants, you can see this exam covers an absolutely incredible amount of knowledge. But you know, it's so much more than a test, right? Every single one of these questions represents a real patient, a real crisis.
All this knowledge isn't just about passing some test. It's about saving lives in real time under immense pressure. That ability to instantly recall the ABCDEs, to tell the difference between two squiggly lines on an ECG, to spot a tiny battery on an X-ray, that is the foundation of everything they do. And it kind of leaves you with this one final thought. For these doctors, the final exam never really ends. Every single patient who comes through those doors is a brand new test, with the highest stakes you can possibly imagine.